Hello, my name is Alison St. Germain, and I'm a registered dietitian and also a certified eating disorder specialist for Iowa State University, and I work over in the Thielen Student Health Center. And this is the next video series on looking at medical nutrition therapy and how you do it without focusing on the weight and then also not doing it in a diety way. And so today we're going to do the first part of an eating disorder series, and it's called Unintended Consequences of Healthy Eating and Exercise Education. Okay, so again, all the information materials will not focus on weight, but focus on health, even if weight loss might play a role, because what we're doing here is we're shifting the focus to health-supporting behaviors that lead to sustainable health outcomes without focusing on weight and diets. And so today what we're going to discuss is the problem with how healthy eating and exercise is discussed. And I'll give you some real-world clinical examples from my 31 years in practice. And I've changed enough information so it's HIPAA protected. And then also I'll give you some practical alternatives to use instead and then some key takeaways. Okay, so some well-intentioned words, small well-intentioned words that leave a big unintended impact would be something like eat healthy and exercise more. It could be as simple as that, which gets said a lot because, as you know, healthcare is the model is very short. You only get 15 minutes to do your assessment, education, and all of that kind of thing. And so it might seem like, oh, I can just say, let's eat healthy and exercise more. But actually, it can unintentionally lead to outcomes that are triggering for an eating disorder. And for example, someone who hears that then might only eat healthy food and they won't eat anything else, and they get very OCD about it and very unbalanced. And also, if you tell someone, well, just exercise more and haven't really found out how much they've been exercising already, they will then try to add in more exercise on top of that. And so the way we talk about food, weight, and exercise can shape behaviors, beliefs, and long-term outcomes. So this advice sounds harmless, eat this, not that, but it just reinforces rigid food rules and then also can fuel the good food, bad food mentality. And we have a lot of that going on in social media already. We don't want to contribute to that. And then it can escalate restriction or it can escalate binge cycles as well. So why does this matter? Eating disorders have a very high morbidity and mortality rate. And patients often present in non-obvious ways that they have an eating disorder or even disordered eating, because the majority of people with eating disorders are not underweight, and then they often get missed because any body shape, size can have an eating disorder. And oftentimes it gets disguised as healthy eating, or I'm just eating this way in order to perform my run, improve my running performance or whatever sport they might be in. And then also it gets disguised as, well, I'm doing this to be healthy. And also food intolerances and gut issues. I see a lot of people that come into my office with that and not saying they have an eating disorder, but after I do the screen, I do detect that they have eating disorders. So everybody with an eating disorder does have some type of gut or food intolerance problem. It's not necessarily a food intolerance problem. It stems from the eating disorder itself. So now, not everybody with gut intolerance or gut issues has an eating disorder, but everybody with an eating disorder has some type of GI dysfunction. So typical and common nutrition and exercise educations make eating disorders worse. It can trigger one or it can exacerbate one that's already there. So again, as we've discussed in other videos, that weight loss recommendations can be problematic, and especially problematic if no assessment of the relationship with food in their body is done and no screening for an eating disorder, because this can trigger relapse, and then it can also initiate disordered behaviors in vulnerable patients that otherwise wouldn't have had this issue. So we hear a lot about trauma-informed care, and so obviously some of the issues that we talk about in eating disorder care will trigger a trauma response, but it is our goal that when our patients leave our office that we don't send them out there feeling worse than when they came in. And so always practicing under a trauma-informed lens is super necessary and best practice. And what I did on this slide is I have some examples of trauma that people have experienced, and it's all related to weight or how someone experiences food and their body. For example, being a chronic dieter could be trauma for somebody. An eating disorder, bullied for weight as a child or an adult as well. Any domestic violence and or sexual violence or physical abuse, food insecurity as a child and also as an adult will actually create that famine and feast type mentality where if they don't have food, they're not going to eat. And then when they get some, eat as much as they can. That's just a biological response. And that then can be carried into adulthood as well, even if this happened as a child. And then weight stigma from friends, family, and healthcare providers too is traumatic. And there's more. That's just a few. So trauma influences how people feel about their body and their relationship with food. So let's say someone came into your office and, nobody knows these underlying traumas, but let's say they came in and they had one of these traumas. And so just think the harm that weight loss would instill if you said, well, you need to lose weight. So I wanted to go through the mechanism of harm from 3 different points. So the cognitive and psychological effects. What happens is when somebody is trying to restrict what they're eating, or they go on a diet or try to lose weight, their food preoccupation increases. And then if they eat something from the, quote unquote bad list, then they feel guilty. And then it can increase shame. As far as behavioral effects, there's the restriction that then exacerbates the binge, and then it might lead to compensatory behaviors, which means over-exercise or purging. And then the physiological effects would be weight cycling. And so when I have a student in my office, I always ask about the weight cycling, like how often and how much weight have they lost, have they gained it back, and that sort of thing, because that actually is a trauma as well of losing the weight and regaining the weight back, and then it makes it harder and harder to lose weight the next time, and it's just a vicious cycle. So here are the client scenarios that I wanted to discuss. So first, G came in to me with PCOS, and she was told by a provider to decrease her carb intake, exercise, and lose weight. That's a pretty typical recommendation for somebody with PCOS. So what she did is she went to, of course, TikTok and social media to figure out what to do, went online, and she eliminated all grains. And so obviously the provider didn't mean for this, but when given just a short example of, okay, this is what you need to do, they take it the wrong way and find the wrong information. So eliminated all grains, all cereals, pastas, rice, and added sugars. So very low carb intake. And so someone with PCOS already has a strong craving for carbohydrates because of the hormonal imbalance there. So she had even bigger, stronger carbohydrate cravings, especially for sweets. And she already had binge eating disorder. And so what happens when somebody who has binge eating disorder restricts? It exacerbates that binge cycle like no other. And so It's unbelievable how many patients with PCOS also have binge eating disorder, because what they've been trying to do is lose weight, which is, what they've been told, and it just perpetuates into this restrict binge cycle. I also have another video in this series specifically to PCOS. If you haven't watched that one yet and you're interested, that would be a good one to go to. So when she came into me, that's what we worked on her relationship with food and her body, and really worked on stopping that restrict binge cycle piece of it, and thinking of the binge is not the actual problem. It is a result of what happened earlier on and leading up to it. And so it's kind of a flip in thinking as well. And in part 2 of this series, we'll talk in more specifics about that. So F wanted to lose weight. And so he was told by his provider, you need to lose weight, but don't diet. Just eat whole foods and avoid processed foods. Sounds like legit, advice, right? Well, he cut out all convenience food, restaurant foods, and he only ate fresh organic produce, fish, and meat, and then got so obsessed over it, started milling his own flour and made everything from scratch. And as a busy college student, that, of course, really was cutting into being able to study and getting good grades, because there was so much focus on preparing the foods, and really developed a fear of eating anything that wasn't made by him or anything that was, processed at all. And so he developed orthorexic patterns and was fearful to eat most foods when he came in to me. And then we had Jay with pre-diabetes. And they had an A1C of 5.4, so not in the pre-diabetic range at all, because 5.7, as you remember, is for pre-diabetes. So closer to non-diabetes than full-on diabetes or even pre-diabetes, because full-on diabetes, you'll remember, is 6.5%. And their fasting glucose was 118 milligrams per deciliter, so that was high, and it was fasting. And so they were just told, well, diet and exercise and lose weight. And so what he did was he cut out all added sugar, significantly decreased his grains, and was only eating what he, termed as healthy foods, but I like to switch the language to nourishing. And when he came to me, he had lost 26 pounds, which was 13% of his body weight, and that was just in 4 months. And he met the criteria for anorexia nervosa. His friends were the ones that convinced him to come in and see me, because they said, hey, you seem like you're really struggling here and you're hardly eating any foods. And so that was great that their friends were, really looking out for them. And then we have H with anorexia nervosa and gut issues. She went into her PCP because she just, everything she ate, she got to the point where she wasn't feeling well. And so was given information on FODMAPs. I mean, that's all I know. I don't know exactly what was said. And so anyway, her plan was to do a full elimination of the FODMAPs, but in the meantime, had an appointment with me. And so giving somebody FODMAPs, especially the elimination piece of it, is really harmful, especially if somebody already has an eating disorder. It can even trigger an eating disorder that hasn't developed yet, because oftentimes people will do the elimination piece and then never add the foods back in. They are not given proper education around it. I personally don't ever do an elimination diet, because you just don't know. And so what I do, I have a handout for that too, and I can link it in the notes here too. But it's a non-elimination FODMAP, and we go through each of the sections and kind of determine, are any of these foods bothering them? And they'll explore it, because they might not know right offhand. And then if so, are there any patterns? Is it one section? Is it the fructose, or is it the oligosaccharides? Is it the monosaccharides? What is it? And so we look at it together to draw any conclusions. And sometimes it's just a matter of, okay, I can't eat all the foods in that section in one day, but if I just have one, I feel fine. So that's how I do the FODMAP piece, because it is so different for every person. And so it's just too risky to tell someone, hey, here, do the cell elimination diet, especially if they're not being followed by somebody who really understands that whole process. And so best practices then, of course, are to screen for disordered eating. And I know you're going to say, we already are doing so much and asking so many questions, which I know you do, and you have 15 minutes or 20 minutes or however much you have. But I'll show you just a few quick things you can say or ask as you're assessing them, so it shouldn't add on any more time, and then you can decide to refer on from there. I'll give you some neutral language ideas, and then shifting the focus from weight and dieting and restriction to some health supporting behaviors, which we've talked about in the past videos as well. So as you're doing your assessment, just some simple, non-official questions that can help lead you to decide, okay, does this person, need a full screen for an eating disorder, or do they need to be referred? And so depending on what you find out, if you're like, oh yeah, this makes me question their relationship with food in their body, you can just refer on to me or the other dietitian on campus who works with the individuals that are living in dorms, the ISU dining dietitian. You can refer to her as well. So how do you feel about how you're eating? Just that simple question they might say things like, well, I don't have time to eat. I'm only eating one meal a day, or I'm just not really getting hungry. I mean, you might get a lot of information just by that question. And then you could say, oh, well, do you ever skip meals when you're hungry to lose weight? That gives you a lot of information. And then another one could be, do you feel like you can't stop eating once you start? And then, have you ever struggled with food or weight in a way that felt out of control? So now, if their answer, if you don't know what to do with it, or you feel like, oh, I haven't been trained on this is way beyond my scope, please refer them to me, and I can do a full screen, and then I can let you know what criteria they meet for the eating disorder, and then you can diagnose them, because I can't diagnose. So some language here that can be helpful. The left side is weight stigmatizing, the right side weight neutral. So now I've looked at several resources, and they all can be different, so I just combined a few, because something that's stigmatizing to someone might not be to another, and something that's neutral to one might not be to another. So it just depends. So the weight stigmatizing terms, overweight and underweight. Over what weight, under what weight. So just using higher or lower weight or high-low is sufficient. Excessive weight can be stigmatizing. Weight management, that puts the ownership in the individual that they can control and manage their own weight. And it's more out of our control than one would think. It's not just about food. It's just not about exercise. There's so many other factors involved that we don't really talk about that much. And so from here, I could spin off into a whole lecture on the social determinants of health, but I'll spare you that. So obesity in itself is a stigmatizing term because it actually means in Latin to eat oneself. Yes, it's a medical term, but that doesn't mean that we have to actually use it. And for dietitians, they're taught, it's called the nutrition care process, and they are taught to find a problem, the etiology, and then the signs and symptoms. And one of their choices is actually obesity. However, when I used to teach, and still when I'm a preceptor for dietetic students, if that's what they come up for their statement, it's called a PES statement, I make them redo it, because obesity is not the problem. It's a sign or a symptom of some other problem, even though the nutrition care process and everything out there says that it's a problem. It technically is a sign or a symptom. And what happens is if they don't come up with the most pertinent problem, they're not going to actually get to the result, right? So, and then oftentimes they would just put the obesity was related to not eating enough fruits and vegetables or something like that, or not exercising enough. And that really doesn't get to the real answer of what we can do to actually give recommendations to, because for all we know, they are working 2 jobs, don't have time to exercise, and the only food they can get on the table is maybe stopping at fast food. So just telling them, oh, you need to eat less and move more, not helpful. We need to, dissect it and figure out what can be helpful for them. And then also skinny. Can be stigmatizing. Fat, I have on both sides, because there is an advocacy group that is trying to reclaim the word fat. Just like a body has muscle, a body has fat, but because of our weight stigma in the world, fat is an insult usually for people. And so if we can kind of think on the lines of fat giving us the same emotional response as muscle, that could be helpful. And then combating childhood obesity scares children, that if they eat anything off the bad food list, they're, going to gain weight and be sick. War on obesity, or the obesity epidemic. So some of the neutral terms, again, high or low weight works well. Living in a large body, person of size. I just go off of what the person calls themselves. Like, I would never call somebody fat, because if they don't call themselves fat, that would, be stigmatizing to them. And middle of the road can be used for average or, normal. So, and then BMI over 30 or BMI under 18. Now, if you watch the BMI video, you know my views on BMI, but it can be less stigmatizing to frame it in that way instead of obesity. And just other language that we hear all of the time that seems harmless. I personally don't even like the term healthy food anymore, because it has been so co-opted by dieting culture that healthy foods just really is like, okay, this is all you can eat in order to be healthy. And it gives me a bad feeling. So you'll hear me say nourishing and nourishment more often. If I say healthy, I usually put it in quotes. Guilt-free foods. Food should not produce guilt if eaten, because it's not a moral issue to eat certain types of food, but we've made it that. Yes, we have more nutrient-dense food than others, but that doesn't make it a bad food or bad that you've eaten it. We have lots of reasons to eat. Fuel and nourishment is just one of them. Taste, if you're just eating, because this tastes good, that's still a reason. It's not a bad reason. And then also, people will eat certain foods where it reminds them of their culture or it reminds them of their family. So there's more reasons than just nourishment to eat food. Junk food is another diet culture word. Avoid or off limits. And then cheat day. So some more neutral terms instead would be, instead of talking about calories, especially with the eating disorder population, I oftentimes will say fuel or energy instead of calories, because depending on their eating disorder, but for example, if someone has anorexia nervosa, the act of eating calories and actually gaining weight is super fearful. So if we treat it more like, okay, this is your fuel in order to be able to continue with school. This is your fuel to make sure your body is running, that sort of thing. It can soften it and just really help with recovery. And then, like I said, we have nutrient-dense and less nutrient-dense foods, and I described that to them. So like something that has protein and carbohydrates in it, and some vitamin and minerals, that's nutrient dense. Where something that is less nutrient dense may be like gummy worms. It has sugar in it. It's just carbohydrates, and so it has less nutrients than the nutrient dense foods. All foods do provide nutritional value, no matter what. Even the gummy worms provide energy. And so can you survive on just gummy worms? No, you need also nutrient-dense foods. But when people start releasing some of those food rules and allow those foods in and they're not feeling guilt around it, their body automatically is going to choose mostly nutrient-dense foods because they'll notice that they have more energy, their cognition is better, but they'll still eat the gummy worms, as a treat or something like that. And it's not, if somebody is purposely tightly regulating it, that always gives me pause because that's just not sustainable if someone has to tightly regulate it. This type of eating, like I'm describing, happens through, work, through recovery work, intuitive eating, that sort of thing. So some of the health supporting behaviors, and these are the same or similar to the last videos, where we talk about nutrition in a flexible way. And we talk about the relationship of food and their body and the relationship with exercise or movement. And then also, I think two things that are very much overlooked are sleep and stress management. Both of those things actually change your hunger and fullness cues and then can change how you feel about your body too. And it seems obvious that, you are in better health if you have less stress and sleep. But actually making some goals around it can be super helpful. And so you've seen this slide before if you've seen the other videos. So the gentle nutrition piece means that it's flexible, it's not rigid, it's weight neutral. We're looking at nutrition by addition. And the number one thing I look for and try to help students with, no matter what, is consistent eating patterns. That in itself will actually help take care of some gut issues that people complain about, excessive bloating and not feeling good when they eat, by just eating on a regular basis and not going long periods of time without eating. And the same thing with PCOS. Diabetes, consistently eating really helps those big glucose fluctuations so it's not like a roller coaster. And so that's usually my number one that we work on. Sometimes I get really motivated clients that come in, they want to do all of the things. And so I have to rein them back in and back up. And I'll say, okay, let's just try consistently eating first. And then we tack on the flexible rule of threes, which is eating at least 3 meals a day. And each of those 3 meals needs to have at least 3 of the food groups, can have more. Protein, carbohydrate, and then something else. And depending on the person, we might talk about adding in more fiber. And for sure, especially those that have been eating very low fat, we talk about adding in fat. So it just kind of depends on what their condition is when they come in. And so the flexible rule of threes, which I can put that handout as well in the notes, that is super helpful. And the handout itself is generic, but you tweak it according to the condition. And it's just really easy. It's really helpful, and people don't have to count calories, and it gives them some structure, but it's flexible. Okay, so now on to the exercise piece, because believe it or not, more exercise isn't always better. And so I wanted to have a little conversation around exercise, because the amount of times that I have heard, even from a personal experience of, because I have had an over-exercise issue in my life, and I'm paying for it now with injuries, but nobody ever took it seriously. None of my PCPs, they're like, oh my God, exercise is good for you, and blah, blah, blah. And I'm like, and as I was recovering, I just had to kind of let that go in one ear, because there is a problem with over-exercise. It's just like with anything. If it's too much or too little, that's where the problem comes in. But because there are not that many people that over-exercise, it kind of gets forgotten about. But just like nutrition advice, how we talk about exercise can have unintended consequences. Exercise is frequently tied to weight loss messaging, and so people who have gone on diets will tie in the exercise piece. So when they're not dieting, then they're not exercising, and there's that whole arena as well. And somebody with an eating disorder will use exercise as obligation. They feel like they have to do it, because if they don't, they're scared that they're going to gain weight. It can be used as compensation for eating too much, and can be very rigid and compulsive. And coupled with, if somebody also has an eating disorder and over-exercise and OCD, that is a real difficult mix and can get super rigid and difficult to treat. So some common clinical messaging that can be harmful. These are the guidelines out there for exercise. And I never recommend that you tell anybody that because, number one, someone who's not exercising at all, they're going to look at those recommendations and they're going to be like, no, thanks. Somebody who already is exercising a lot will follow this and then some. So it's just not ever very helpful. I talk a lot about just functional movement in my practice where I encourage people just to get more movement throughout the day. So every time they use the restroom, go ahead and do a brisk walk, 5 minutes, go up the steps, do whatever, just to get away from your desk and to move. And if you do like the gym, that's fine. Not everybody does, but just trying to find different options for everybody. Because somebody who's not working out at all is not going to go to 150 to 300 minutes of moderate exercise. So I don't even use those guidelines. And so anyways, just some things that people commonly say are, okay, exercise to offset what you're eating. And then if you want to lose weight, you need to be more active. So those two statements can be problematic because it reinforces that exercise is the reason for exercise is to burn off the food that you've eaten. But that's not the reason for exercise. The reason for exercise is to have a healthy heart, and activity, movement helps you stay flexible and helps you lead a good life, right? And strengthening bones, strengthening muscles. And so it's not supposed to be used for burning off food. And a lot of times people don't even recognize that a bulk of your calories go to just your basal metabolic rate. I have that conversation daily in my office many times a day because people who aren't science people don't understand that you need a bulk of what you eat is required to keep you breathing, your heart beating, and just, your body at rest. And so we already talked a little bit about that massive amount of exercise on there seems like a lot for people that don't exercise already. So just asking them, do you exercise or have any physical activity you do on a regular basis? Because not asking them, that is, you're kind of thinking, oh, they're not exercising already. And so anyway, this can escalate into overexercise, guilt when the goal is not met, and then injury or medical instability. So what disordered exercise can look like is REDS, and I've seen this several times. It can really be disguised as like a sports performance thing. And so REDS is the newer, it's not new, but it's the term that's used now instead of the female triad because it encompasses, everybody, not just the women. Exercise during illness and fatigue is very common with over-exercisers, and a lot of anxiety if they miss a workout. So I like to find out, is this, because they'll say, running or exercise is my therapy. It helps me become less anxious. That's different than anxiety related to, oh my God, I didn't work out, I'm going to gain weight, whatever it is. So I really like to play that out and clarify because that's really different. And that anxiety piece on if they miss a day is a really important clue to what's going on. Rigid rules and tracking of time, intensity, steps, and calories burned. I have students that are very tightly calculating what they eat versus what they expend, and it can get very obsessive and compulsive. Sometimes it can get so bad that they're missing events, they're missing class or whatever because they need to get their workouts in. They keep adding on to what they're already doing. So I think it's important when you're working with students is to normalize rest and variability. So helping them explore types of movement that they enjoy. So not everybody likes exercise, going to the gym, but some people like physical activity where they might want to go play soccer or basketball, and that's totally fine. To be healthy, you don't have to actually go to the gym. And then that's when I bring in the whole movement piece of, just adding in extra movement throughout your day can be a good start and very helpful. Explore their energy levels. Somebody who is over-exercising and under-nourishing usually has a lot of fatigue. and their cognition has lowered too, and they're having trouble concentrating. And then emphasizing rest days are important as well, because your body needs time to rest and recover and re-nourish for the next workout too. And so help them reframe that consistency doesn't mean I have to do this every single day and for so many minutes, because that's too rigid. So helping them, with that piece of it as well. So some key takeaways here is language matters, even though we're all in a rush and we feel like, oh, it's better just to say exercise and eat healthy. People already know that. And so actually saying it can actually do more harm than good. Weight stigma, toxic diet and exercise culture influences everyone, even us, the healthcare professional. So we have to always check our bias there. Small language shifts can prevent real harm. And then collaborative care improves outcomes. So I'm always happy to talk with you about this, and also happy when you refer patients to me, because my model is around the counseling model, so I get more time. I get more than 15 minutes. So please just refer to me. And here are some resources. I'll also have those linked in the comments section, along with those other handouts that I talked about. All right, thanks.